Folks, this episode has been years in the making, and for reference, why all you have to do is look back and search on YouTube VMR with Dr. Usha George, and you might consider consuming that entire episode to really set yourself up for as much success as possible today, or as much learning as possible today, because we have the return of the legend, somebody who has been part of the CP Solvers journey for a very, very long time,
Thank you. You're
since its
too kind.
inception, really. But Usha, maybe I'd hand the mic to you to sort of update people on how you've been, and
All right.
yeah.
I'm a hospitalist, a chest physician. I practice in Malaysia. Um, and I just screwed up a bit. And it's just been an amazing 5-year journey with the clinical problem solvers. And I've learned in the course being an examiner, and similarly the junior doctors and medical students. And I've recommended a lot of them to get on board on the clinical problem solvers. And it's been just, I think what Rabih and Riza are doing, there are many, many podcasts around, but they may last a year, 2 years. But this to go on for so many years, it's just, I'm just glad, so glad to be part of it.
You're so kind. Yeah, I've only started to get some white hair recently, Usha, so my time is fading. But the next generation, as you can see on the video screen, is alive and well. And since your last involvement here, what has developed is that there's now an internal group of people who are actively pushing themselves to be the best version of themselves in the realm of clinical reasoning, who are part of the CP Solvers Academy, most of whom are here and have their video on. So I encourage all of you to check that out and follow the path that Usha is outlining here. But of course, before we jump into the case, I'd love to thank everybody who's making this happen, starting with our beloved Simi, who is scribing. So Simi, maybe I can hand the mic to you to say hello.
Hello, everyone. Very excited to have Dr. Usha with us today and excited for a discussion by my mentor, um, Noah, and my friend Rabih.
Thank you, Simi. Sarah, thank you for hopping into Teaching Points. Mike, to you to maybe give folks an update on how life is treating you.
Yeah, hey, this is my first time doing teaching
Oh,
points.
nice.
Very
Yes.
excited to jump on that. And life is treating me well. Just applied to residency, so I am, anxiously awaiting the invites that may come in. And excited for what's to come.
I feel like the folks who have been part of the CP Solvers quote unquote program very likely to have a healthy list of places to be interviewed at. You never know with this match process. It's always complicated and tricky, but set you up for success. I should have forewarned you that I think you're going to have your work cut out today. Usha's cases are very, very rich with learning. So I'm glad you're jumping into the deep end of teaching points. But I know you're more than up for it. I'm also very, very glad that I have a not quite a mentee discussing with me. I would say a colleague at this point. Those of you who don't know Noah, that's probably could only be true if you've joined the CP Solvers recently, because he is now an R2 at WashU, and I think he, to outline what Usha said, is literally symbolizing what CP Solvers has become over the 5 years. In fact, for those of you who don't know, Noah was probably the 50% of the reason why the academy was created. He was not yet a team member, but Marcella, one of our long-term members, was like, "Hey, I know this really smart, kind guy. Why don't we have him present a case to us privately?" And when Noah showed up and did it and wowed us all, we were like, we should do this more often. And that's how the academy was born. And now Noah is essentially in high-level leadership positions on the podcast and many other things. So very, very excited to go discuss with you, Noah. I think it'll need our combined cognitive power to even approach Usha's case today. Let me hand the mic to you to say hello, and we can jump in.
Hey everyone, super excited to be here today. This week is actually my return to CP Solvers after my sister was visiting from Brazil and I was on nights. But I collected a ton of cases. looking to present some rapid fires to the Academy group. And this week, you also recorded the next Clinical Known series episode, which is great with a surprise guest. And then we also recorded the schema episode yesterday. So watch out for those podcast episodes.
Amazing. You hear that podcast voice in him? All right, Usha, Mike to you.
All right. So I'm going to present 2 cases today, but we should be able to finish on time. Each case will have 4 aliquots. And at the end, before the final reveal, we will conclude both the cases simultaneously so that we can sort of define how it ends. All right. So the first case, 60-year-old male, history of asthma, diagnosed 3 years back, presented with worsening symptoms of cough and shortness of breath after an upper respiratory tract infection 2 weeks back. He gives a history of frequent asthma exacerbations in the last year, needing rescue oral steroids. He has associated rhinitis. He denies fever, chest pain, joint pain, or rash. He's a non-smoker, retired administrator, no significant medical or family history, no recent travel. His medications include a nasal spray, triple inhalers. He, however, also confessed to taking regular traditional Chinese medication, which normally contains steroids. That's the end of the first aliquot.
I think both Simi and Sarah have their work cut out today. 2 cases. Very, very excited, Usha. Noah, what are you thinking?
This is a very interesting case. I think that my first reflex thought is that as I progressed through residency, I started to take things with a grain of salt, right? So there was this wonderful case that I think Marcella presented, which was a case of this person who had this diagnosis of COPD, was on home oxygen, and kept coming back to the hospital with exacerbations of the COPD. And then the physicians and the providers that saw this patient kept giving steroids, inhalers, and they would get better and they would send them home until finally one day they didn't get better and they did a chest CT and they saw like BO, bronchiolitis obliterans. They went back to the history and the patient actually had some symptoms of RA, and then rheumatological markers were positive and the patient was diagnosed with RA-ILD. And when you go back to that patient's history, they didn't have any smoking history and they didn't have PFTs. So they had this presumed COPD, which lived on as a chart diagnosis, and then it kind of framed the case very nicely for the providers, but in a wrong lens. And here, when I hear a 60-year-old person with asthma diagnosed 3 years ago, I'm not saying it's impossible, but I'm saying, hey, it's kind of weird story, right? We know that asthma usually, most cases present earlier in life. You can have adult onset asthma, but I'll be really interested to see how this asthma was diagnosed. Was it because this person kept coming in with symptoms of wheezing and shortness of breath, and then the providers made a presumptive diagnosis based on this intermittent episodic nature, which is fair, asthma can present like this? Or was it like a more rigorous testing with PFTs showing reversible bronchodilation? So this is where my mind is, because if it is a true diagnosis of asthma, then we're in the realm of like uncontrolled asthma or asthma mimics, disease that can present with reversible bronchodilation. If we're not confident that this is asthma, then it becomes more of like a respiratory illness predominantly, and I'm framing this as respiratory based on the cough and the absence of like chest pain and peripheral edema, and chronic, episodic, or chronic, intermittently flaring disease, which would make me think of other pathologies other than asthma. I don't think we need to necessarily get into like the fine differential diagnosis, but those were my initial thoughts.
Yeah, I'm right there with you, Noah. I think if we adopt a mental model of all diseases being a sum total of intrinsic vulnerability and extrinsic triggers. So you really think about it, like COPD, for example, is an extrinsic trigger, smoking, causing a permanent and progressive intrinsic vulnerability. So what is asthma really? Asthma is actually mostly a disease of extrinsic triggers with a static non-progressive internal vulnerability. And that vulnerability is airway hypersensitivity. And fundamentally, asthma is no different than an overly simplistic model of me walking into a room that has a tremendous amount of cologne or perfume and sneezing. And the vulnerability is that most people who walk into that room don't, but I do. And so I have asthma of my nasal passages. And so if it is true that somebody has asthma, there often is no uh, uh, clue to the existence of that disease unless you do something specific, which is to challenge the patient. And so if you ask yourself, what is the cornerstone of the diagnosis of asthma? It's to actually prove that absent a trigger, the patient has flawless airways and has no problems. And it's only when you give them methacholine or you give them a bronchodilator do you see that that vulnerability to sneezing diffusely in their intrathoracic airways exists. And so a simple mental model we can adopt for this patient is to say, because of the age at which he started to sneeze with perfume exposure and the relentless progression of it happening, you have to wonder, does he have more of an intrinsic vulnerability than asthma has? And you outlined the details of that thought process so well. And I think that's where we're going to have to track. And one big clue, Noah, is asthma should have no cumulative complications except the burden of sneezing over and over and over and over and over again. So if there are cumulative complications, dyspnea on exertion, X-ray features, then the patient doesn't have asthma. So I'm right there with you, and I hope all of you will take what is a complicated disease, asthma, and realize its fundamental simplicity. There's a mild internal problem, airway hypersensitivity. Most of the issue is outside the body. All righty, Usha, mic to you.
Perfect. I think I agree with Noah. Sometimes it's useful not to take a diagnosis at face value. All right, so the examination, the patient was Cushingnoid in appearance with some superficial bruising. He was comfortable, afebrile with normal vitals. ENT examination revealed a rhinosinusitis, and respiratory examination revealed bilateral expiratory wheeze. Rest of systems examination was normal. Right, that's the end of the second aliquot. Shall I go into the investigations? Or
Yeah, well, Usha, I know you strategically planned this, so we will follow your lead and reflect real quickly, and then and take it from
all
there.
right.
Yeah. So Noah, go for it. What
So
do you
the
think? Oh, sorry. No, go ahead, Usha. Whatever you had planned beforehand, please. We'll follow your lead.
Okay, so the investigations, we'll start with the blood test. The full blood count is normal, hemoglobin of 13, total white of 6.6, with eosinophils of 2%. He had a normal CRP. He had a raised serum immunoglobulin E, IgE. Now, interestingly, his fasting cortisol was less than 30, normal being 101 to 536. A CT scan of the lung was done. I want to share the scan. Wait, can I share the scan?
Perfect. Thank you, Usha.
The scan was well, maybe we'll save the. Right, I'll just. Okay, we'll focus on this particular section, and it was reported as predominantly bi-basal consolidation. And all right, and stop the share. Great.
Fascinating.
All right, so this was followed by spirometry. It revealed a moderately obstructive pattern with an FEV1 of 58%. A cardiac echo was done, normal ejection fraction, right ventricular systolic pressure was normal at 20. An autoimmune screen was sent, ANA, ENA, anchor, and the results were pending. Okay, we'll open the discussion now.
Oh, thank you. Thank you so much, Usha. This is very, very interesting. Yeah, Noah, keep flowing, my friend. What do you don't need direction from me at all. Keep going.
Yeah, I think it's a very rich aliquot. And then to summarize, we have a 60-year-old person with intermittent wheezing and dyspnea with maybe some residual symptoms. And then the investigations, the notable things for me that stuck out is that they have eosinophilia, right? They have like 2% eosinophils, I believe.
No, actually the eosinophil count was normal.
Oh, it was normal. Okay.
Yeah, perfectly
So
normal. Yeah,
no
no
eosinophilia.
eosinophilia.
Okay.
Raised
And-
IgE, no eosinophilia, normal CRP.
Okay. So we have raised
And a
IgE,
low cortisol level.
low cortisol, and then consolidations on the CT scan.
Yes, consolidations on the scan.
So what is interesting to me is that the patient, I feel like there are a lot of like tensions in this case. There are a lot of like nuances in this case. So the first one for me in the physical exam is like the person has Cushingoid habitus. So that indicates to me that they're receiving quite a bit of steroids, right? If they're receiving so much steroids and they're still having symptoms, it's an interesting tension point, right? Because we would expect most diseases, including asthma, to be very steroid responsive. So that's the first tension point. The second tension point for me is the CT scan findings. Asthma consolidations, I don't know how to reconcile that. So another thing that challenges that initial diagnosis. If we think about like chronic pneumonia over a couple of months, it seems like then we get into a different differential diagnosis, ILD based, maybe like organizing pneumonia, chronic eosinophilic pneumonia, or maybe a indolent pathogen that we're not targeting, maybe like endemic mycosis. So that's kind of where my mind is going. It's like straying further and further away from asthma. And then finally, the IgE level being raised. I don't know how much value to put into that. I know that, in asthma patients who have elevated IgE levels, we send the ABPA cascade. Here, sure, like we can send it, but I don't know how relevant that is in a patient that we don't fully believe have asthma. And then the cortisol level being undetectable, yeah, I can see a patient being chronically exposed to steroids, developing Cushingoid features, and then now at this point that we're meeting him, they don't have steroids on board. They're adrenal insufficient from the exogenous steroid ingestion. That's kind of how I'm explaining that. What do you think, Rabih? I think I'm kind of like all over the place because I feel like we have like little clues in different systems. I'm having a hard time putting it all together.
Yeah, I think it's impossible. I think your difficulty is not intrinsic to you, but extrinsic in the form of the case itself. And I'm just going to keep talking in that parable the whole time. And I think now you've proven that this cannot be asthma alone. Either this is not asthma or a complication of treatment has been incurred because now you have alveolar disease in the form of a consolidation. So let's remember the strict definition of asthma. It's an airway hypersensitivity syndrome triggered by exogenous allergens. And the presence of a consolidation means that asthma is not the only disease here if it is at all present. And the two possibilities are this is not asthma at all, or the patient has suffered a complication of the treatment of asthma with the amount of steroids he's getting. And so I think you might ask yourself, is this, well, I should just reflect some more with you on the PFTs. So on the PFTs, we see the patient has an obstruction. And so what does that mean? Does that mean that he has an intrinsic airways disease? And now the problem that we're trying to solve is a patient who has sinus disease, intrinsic airways disease, and alveolar disease, which is an interesting spectrum, that his entire respiratory tract from nose to alveolus is diseased. And I think that's an interesting lens to adopt. The other possibility is his airway hypersensitivity is so bad and so severe that he is clamped down even when he's doing his PFTs. And that's the tension with asthma is when you do PFTs, ideally the patient is not symptomatic and you don't see evidence of airway obstruction. And so you give them methacholine challenge to try to bring out that hypersensitivity. However, in advanced, undertreated, or acutely exacerbated disease, you'll see that hyperreactive airways, and then you'll prove that it's actually a hypersensitivity by doing the opposite of methacholine, giving a bronchodilator and allowing those airways to breathe. And so I may have missed it, but I don't think we had that element of proving that there's airway hypersensitivity with bronchodilator response. But I think you ask yourself, well, are we proving that these airways are very, very stubborn by the fact that the patient is Cushingoid, getting so much steroids and still clamping down? And so you might say, airways that are blocked even when the patient is Cushingoid, that doesn't add up. And so the final elements of this are, how do you reconcile the fact that his exam says he's getting a lot of steroids, but his lab says he's not? And there are three possibilities, I think. One is the exam is imprecise, and determining a Cushingoid habitus and distinguishing that from other issues is difficult. In the hands of a seasoned examiner like Dr. George, I'm inclined to believe it. So I think the two other possibilities are more real. The first is that he actually has intermittent steroid exposure and he is cleared the AM cortisol now, but because his last dose was over 12 hours ago. The last possibility is he takes a steroid that the lab doesn't pick up. And I want to try to see if this neuron is stuck in your head. Do you happen to know of a steroid that doesn't get picked up by the assay?
No, I don't remember.
So there's a reason we use dexamethasone suppression tests for Cushing's disease. We give the patients dexamethasone and try to suppress their own cortisol. But you may ask, well, isn't the cortisol assay going to pick up the dexamethasone itself? And the answer is no. That's why we pick dexamethasone over any other steroid. If you did the prednisone suppression test, you would detect cortisol because it's picking up the prednisone that you're taking. So you can remember those two facts and collate them together and merge them into one phenotype as dexamethasone. So either you're taking a lot of dexamethasone or his last dose of steroid was too long before the assay. So I think this patient is still clamped down, still has an elevated IgE despite the steroid. So either he has a steroid-induced complication or he is so spastic, unlikely from just benign asthma alone, that a condition that is really, really aggressive and atopic is causing him to be irritated here in his lungs and extending into his alveoli. And so I'm inclined to wonder about a secondary asthma entity that you already proposed a various number of them, and would discard the fact that his EOs are suppressed because I don't think they represent the inherent disease. I think his exam shows why his EOs are suppressed is the whopping amount of steroids that he's likely exposed to. So this is a powerful, powerful case of disentangling everything that you're seeing on labs, because I think they're all being camouflaged by the clue of excess steroid exposure on the physical exam.
Right. Excellent discussion. And just to his lung function, there was bronchial hyperactivity. There was an improvement of FEV1 for up to 20% after a beta agonist. All right. So we'll move on to the patient's progress. So patient was, he had some resolution. He was discharged on quick taper of oral steroids, triple inhalers, and advised to stop his traditional Chinese medication. 2 months later, he bounced back. He was readmitted with recurrent wheeze. Certain investigations were repeated. His blood count was noted to have high eosinophil count at this point, 12% with an absolute eosinophil count of 1.4. His cortisol had normalized to 160. Now a repeat CT lung was done. There was resolution of bibasal consolidation, but new right middle and left lingular consolidation appeared. His CT sinus revealed bilateral mucosal thickening. And in the meantime, His autoimmune screen had returned. His ANA, ENA, and ANCA were negative. You open the discussion now.
Yeah, very, very interesting. The fact that he does have the reversible bronchoconstriction on spirometry is more like towards the other hypothesis that we're entertaining, which would be like very kind of uncontrolled asthma/asthma mimics. And then in this realm, I know of two big conditions, especially with the eosinophilia and the elevated IgE, the ABPA, which we can send the assay to, and then the EGPA, which is eosinophilic granulomatosis polyangiitis, which could explain the alveolar filling that we're seeing here. And then the fact that the ANCA is negative makes it a little bit less likely, but doesn't dissuade me completely, because we've seen time and time again here in CP solvers and in other spaces how those serologies are good when they're positive, but when they're negative, they can be false negatives. And we have to repeat them. And then if the pretest probability is high enough, we have to get some tissue and get confirmation. So the fact that the ANCA is negative, I acknowledge that. It makes it a little bit less likely, but it does, I think the story here is severe treatment unresponsive asthma. And then if we're going down this path, the patient needs, biologics if we're saying this is asthma. And then before they get biologics, we have to rule out the mimickers, which would be EGPA and ABPA in this case for me. Rabih, what other mimickers or what other conditions do you think could be at play in this case?
My friend, you've laid out everything. And the question is, how do we go about evaluating it, I think? I don't think there's anything else on the list that I'm contending for. I think the principle is always that you should really start to evaluate exogenous triggers of disease before you think of something internal. And so the pathway to clarity on these patients, I think, is to test for Aspergillus as the antigenic trigger for worsening disease. The probability of that is reduced in this patient because of the CT findings. In ABPA, the destruction and disease tends to be in the airways, resulting in bronchiectasis. And so the fact that he doesn't have that reduces the probability of that investigation, but it's still, I think, the first thing to do. Then the second thing to do is to look for internal problems, and there are three of them. EGPA, as you mentioned, hypereosinophilic syndrome, and chronic eosinophilic pneumonia. The latter, chronic eosinophilic pneumonia, is the final diagnosis of exclusion here because there is no pathognomonic feature of that condition. But it is a condition that requires the disease to be restricted to the respiratory tree, which this is so far. So that would be parked further down the line. The tension now is this EGPA or is this hypereosinophilic syndrome? And distinguishing between those two things is actually very, very difficult in early phases of both those diseases, unless the patient is quote unquote lucky diagnostically by having a marker unique to those two conditions. EGPA having p-ANCA positivity, which is a minority of patients, and patients with hypereosinophilic syndrome having mutations that confirm either myeloid or lymphoid hypereosinophilia. Ultimately, it remains an existing battle to try to figure out that plagues chest physicians and rheumatologists to try to distinguish between idiopathic hypereosinophilic syndrome, termed IHES, and ANCA negative EGPA. It's a very, very difficult thing to do, and people often think that these two things are on a spectrum, where patients with idiopathic hypereosinophilic syndrome then go on to develop the vasculitic features of EGPA. The only way to tell between those two things is to do a biopsy. And if a biopsy shows granulomas with vasculitis, that's EGPA. If a biopsy shows none of those features, the patient gets rendered with idiopathic HES. So what would I do in this situation? I think you do all that you can. And all that you can right now is to do extensive Aspergillus testing, as you mentioned, to send off peripheral flow for markers of clonality of that eosinophilia, to discuss with hematology if they're interested in taking it to the next phase by doing a bone marrow biopsy and studying the eosinophils in the bone marrow. And ultimately, time will tell. Because if this patient develops no purpura, no mononeuritis multiplex, no glomerulonephritis, they will likely be rendered either idiopathic HES or chronic eosinophilic pneumonia, depending on whether there are any extrapulmonary features or not. So just purely based on how much I'm talking, you can tell this is a very complicated space. First step, rule out an exogenous trigger, which is Aspergillus. And then the second steps are to talk with many, many people about what this patient may have. And your only way out with definitive clarity now is a mutation in the line of eosinophils, short of a biopsy.
You were
Perfect.
Yeah.
you were mentioning the triggers, and sorry to
Yeah.
interrupt. I just thought about another thing.
Yeah.
So if we're saying that this is like a hypereosinophilic syndrome,
Mhm.
what about, infectious triggers? Do you think
Absolutely.
that like low F1 syndrome could
Yeah.
show up like chronically, or is it more acute in terms of the
Oh,
manifestation?
I think that the possibility that this patient has a recurrent parasitic infection looms large for sure. I think that it's a little bit lower on my mind because of the fact that it remains centered as a respiratory disease despite so much steroid exposure. But gosh, if you told me that you saw some strongy in your bronch, I would believe it 100%. Yeah, I think that's an oversight. We should probably do our due diligence and rule out a migrating helminth like strongy or paragonamyces. Though I think the duration of 3 years now without a more fulminant fingerprint makes that a little bit less likely, but it's a really important thing to not skip over. Thank you for emphasizing it.
Okay, excellent discussion. Just to complete, his IgE for Aspergillus was negative. All right. So we'll move on to the second case. I mean, timing is good on the half-hour mark. Now, the second case is a 45-year-old male. History of cough and shortness of breath of 1 month duration. His shortness of breath progressively worsened in the past 2 weeks associated with blood-streaked sputum. He also noticed a rash on his fingers and toes. In addition, he experienced bilateral lower limb weakness and numbness, causing his gait to be unsteady, worsening over the last 2 weeks. He has no bowel or bladder symptoms, no fever. He works in sales. He's a non-smoker. No other past medical history or relevant family history, and he's not on any regular medication. And we'll open the case for discussion.
By the way, Bob, your parents are awake. Your mom's logged on, I think.
I feel like every time
No,
we
just in
get more
case you don't know.
information, I get more and more overwhelmed. Like this being the first eloquent is crazy. So we have a 45-year-old male with subacute progressive dyspnea, and then with blood streaks and
Yes.
some neurological symptoms with bilateral weakness and
Yes,
worsening
he's got
gait.
rash, neurological symptoms. Yeah.
Yeah, so we have here definitely a systemic disease, which is affecting at least three systems. So the pulmonary system, the skin, and neurological system. I think that the disease that's kind of on my mind right now, because we were so primed discussing, would be like the AGPA with like all those manifestations. But I think a mistake here is to like jump to the diagnosis too fast, right? So if we are dissecting first the dyspnea, I think the presence of blood streaks again helps us center it in the pulmonary system, because other conditions, except if you have like a lot of pulmonary edema with some bleeding diathesis, other conditions wouldn't present with blood streaks in your sputum. Here we don't get a lot of history of volume overload, so I'm really centering my differential diagnosis in the pulmonary system as a kind of like subacute progressive disease. It makes me very worried for this patient, and I think that we need chest imaging as soon as possible. The rash and the weakness in the neurological symptoms, I think they serve here in this case as accompanying symptoms, and then we can frame the pulmonary manifestations after we get the imaging, after we understand better what's going on in the respiratory system. We can use those to kind of narrow down the differential diagnosis. I'll be very interested to kind of localize that weakness in the worsening gait to see exactly what system is, what part of the nervous system is affected. If it's like the muscle, if it's the neuromuscular junction, if it's the peripheral nerve, or if it's more central. So I think that's a very big distinction that I'm looking forward to in the physical exam. And of course, getting a more accurate description of the rash or maybe a picture, I think that will be helpful. I think right now it's too soon to go into the differential diagnosis again, but it's, wide open.
You left me speechless, my friend. I have nothing to add but to commend you on acknowledging the setup for this case, but also moving past it. I think that happens in real life so often, where you just saw a patient and then you see the next patient, you're so primed. So that ability to disconnect, which you manifested for us, was really cool to see. I have nothing to actually add about the thoughts of this case. Excited for the next aliquot.
All right. So examination. Well, he was mildly tachypnic, temperature 37.2, blood pressure 140/80, pulse rate 102, saturating 92% on room air. He had normal JVP, no peripheral edema, remained alert. Respiratory examination revealed bilateral diffuse coarse crackles. He has bilateral distal lower limb weakness, left more than right. He has decreased sensation to light touch from knee downwards. No detectable sensory level. Reflexes are intact. Normal cranial nerves. And he was noted to have bilateral digital vasculitic rash on his toes and fingers. No active synovitis. And we'll open the case for discussion.
Yeah, I think just based on the vitals, this is someone that I'm worried about for sure. I think that the fact that he's hypoxic also helps us narrow down the differential diagnosis, because we can think about the path that the oxygen has to go through to go to the blood, and then we can look for problems. Like, not all cases of dyspnea will present with hypoxia, but hypoxia usually leads to dyspnea. So we have something that's impairing gas exchange. And in the physical exam, we picked up crackles, which to me is translating as an alveolar filling problem again. So we have something that's filling the alveolar maybe diffusely, and that's impairing the gas exchange. Now, the alveoli can be filled by water, pus, blood, or proteins. And we get a sense from the rash that the blood vessels are also compromised in this case. So that's kind of what I'm thinking about, like maybe the small blood vessels in the lungs are being affected, and like the small blood vessels in the skin are being affected, like the small blood vessels that feed the peripheral nervous system is being affected. And that's how I'm kind of like piecing everything together. What do you think, Rabih?
Absolutely superb. I think that when you see the purpura, you recognize that purpura can be caused by many things, and we'll probably release the Academy VMR that we did privately to the publicly soon, so you can reflect on that. But when you see the combination of purpura and then neurological findings in that weakness, in that distribution, I think you can, in real life, take the leap of faith of worry that there is ischemia to the skin and ischemia to the nerves, i.e. that the patient is on the spectrum of vasculitis. I think that should cross your mind. And so as you try to overlay vasculitis with the lungs, you come to the conclusion that the patient alarmingly has high concern for having diffuse alveolar hemorrhage. And so those would be my operating hypotheses that I would superimpose on the common causes of dyspnea and hypoxemia, because it would push me to get a CT scan without, and maybe not skip an X-ray, but quickly get a CT. And so if we are in this space, you ask yourself, well, if give yourself license to be creative and think rare, even though you're just meeting the patient because of the uniqueness of the findings, and ask yourself, what is the base rate of vasculitis causing a peripheral nervous system involvement? And the base rate in that entity would prioritize not a large vessel vasculitis because the vessels are too big, but medium and small vessel vasculitides. And that's where the pulmonary involvement is very powerful, because pulmonary involvement is is characteristically absent in medium vessel vasculitides like polyarteritis nodosa. So you immediately jump to the small vessel vasculitides, and within them, there's the ANCA-associated vasculitides as the primary example, and then systemic rheumatological conditions that then have a secondary vasculitis. So lupus vasculitis, RA vasculitis. And the latter category usually develops vasculitis in the end manifestations of the disease, long-standing and undertreated. So you can quickly say purpura plus nerve, vasculitis, vasculitis plus lung, small vessels, rapidly developing ANCA vasculitis. And so which of the ANCA vasculitides has a propensity to cause mononeuritis multiplex? And it's not the most common one. It's not GPA. It's actually MPA, microscopic polyangiitis, and eGPA, eosinophilic granulomatosis with polyangiitis. So it's crazy to think that it's even plausible to look at a patient, talk to them, examine them, and think MPA or eGPA. But if you really have shrewdly, as Usha just outlined, identified the constellation of purpura, nerve involvement, and lung involvement, you're not dealing with common things anymore. So in real life, I would be excited to have seen, wow, such a bold declaration of a disease. And just like you did in the first aqua, temper that enthusiasm to be cautious and careful and not to get carried away. But certainly in this patient, looking at two things very closely that I might gloss over. The UA for glomerulonephritis, I don't look at that very, very closely. And then the diff, don't order a CBC without a diff in this patient. You may overlook the value of eosinophilia. So.
All right, excellent. So we'll move on to the investigations. Now, the full blood count, hemoglobin of 12, platelet of 135, the total white of 13, and his eosinophil a differential of 31%. The absolute eosinophil count is 4.22. His CRP was markedly raised at 133. His renal profile was normal. His urine microscopy was bland. Sputum was negative for pathogen, negative for AFP staining. His immune screen, ANA, ENA anchor were sent and pending. Rabih, can I share his CT lung?
Please, yes, feel free to do so.
Running it now. Wait. Clearly, and it was reported as extensive bilateral diffuse consolidation at ground glass.
Wow. When Noah scratches his chin like that, he's thinking real hard. What are you thinking, my friend? I do the
I'm
same, I'm
thinking,
told.
Get this man to the ICU right now.
Indeed.
Just get rid of that.
Sarah's
Okay, great.
comment in the chat is
All
so
right, so
funny.
we'll
I
move
love
on.
it.
So we've seen the imaging. His echo was normal, ejection fraction normal, normal right ventricular systolic pressure. A nerve conduction was done and revealed a mixed polyneuropathy. Patient, however, refused a skin biopsy. So we'll open the case to discussion.
Yeah, I think right now it's really hard for me to not anchor on the disease that we were talking about earlier, AGPA. I think that the lung CT findings would be compatible with DAH, like we were mentioning, with the diffuse ground glass and the consolidations. And it's very worrisome to me because those patients can decompensate very fast. And I wouldn't be surprised in the next aliquot if we hear that he is intubated in the ICU, we're doing a bronch, and the lavage is getting progressively more bloody. I think that the fact that we confirm a mixed polyneuropathy is good. I think that is in agreement with our diagnosis. One thing that we didn't mention but could certainly be at play in other cases would be someone that comes in with this dyspnea and cough with blood streaks, and then the rash and the neuropathy is more like long-standing, right? They have diabetes, they drink alcohol, and it's just kind of like superimposed, and we're led to this EGPA diagnosis by mistake because we assume that there's only one disease process at play. I think that the fact that it's a mixed neuropathy, a mixed polyneuropathy makes it more likely. And that's kind of where I am right now. I don't think I'm trying to do the exercise that Jack Penner taught us, which is to assume that I'm wrong, right? Assume like I meet myself 10 minutes from now, and I'm telling myself, hey, no, like you embarrassed yourself, like you got stumped. What is the other potential diagnosis? And I really am trying really hard, but I can't see it, especially with the EO so high.
Right. Yeah, I'm right there with you. I think if you take the liberty of now counterposing these two cases, both of them are eosinophilic respiratory diseases, right? And so you might ask yourself, what differentiates the two? And I think the major differentiation between the two is the presence of PFT confirmed asthma in the first case and the restriction to the respiratory tree in said case. What's different here is the lack of PFT proven asthma, but the presence of a prominent extrapulmonary signature. And I think there's a gap in either of those two cases for the diagnosis of EGPA. The gap in the first case is a prominent extrapulmonary signature, which we're seeing here. And the gap in this case is proving that this disease extends to the airways, which we have yet to show that this patient actually has airway hypersensitivity. And so if you add both of these cases together, this is a classic patient case with GPA, one single case. And so if that's the twist at the end, that would be a fascinating play. I don't suspect it given the differing ages of the two patients, but yes, I think there is something missing in this case. I think it's missing the alternative possibilities of eosinophilia, but also proving that the disease extends to the area, which is a key aspect of the diagnosis of EGPA. Noah, if you didn't know the ANCA result for the first patient, you know it to be negative, but if you didn't know it, who would you predict to be more likely to be ANCA positive, this patient or the former patient? What do you think? Well, for some reason, I see I can't hear you. I don't know why. Is it me? Or can you guys hear
No,
Noah?
it was me. My
okay.
microphone is turned off.
I see.
It's a good question, and I think there is a nuanced teaching point here that I
Yeah.
don't know, because it would be a guessing point.
Yeah.
I would assume the second patient, just given the degree of eosinophilia, but I don't know if it's
Yeah.
a linked or something.
Yeah, I think it's a beautiful concept of the pathophysiology of EGPA, and EGPA develops over years. People estimate that the pathophysiology is one that develops over 5 or 10 years. Initially, patients just have asthma, and then they have an eosinophilic disease where they actually cause GI manifestations most prominently, pulmonary manifestations in the alveoli, and sometimes cardiac manifestations that are all eosinophil driven. And at that stage, the patient is p-ANCA negative and has no vasculitis. The final stage of EGPA is the evolution into a vasculitic phase where patients start to infarct organs, infarct their nerves, infarct their skin. And so what you could be seeing with these two cases side by side is the first patient being in the eosinophilic phase of EGPA before they develop vasculitis, and this second patient being far advanced in the vasculitic phase. So it is actually predictable that a patient, case number one, without the vasculitic features to be ANCA negative. And the patient in this case has a very high chance of being p-ANCA positive simply because of the prominent vasculitic manifestation. So the total odds are 40% in all comers with EGPA. But when you split patients into two different types of patients, eosinophil predominant, which is the first case, or vasculitic predominant, the second case, you get a much differing probability of much lower in the former and much higher in the latter. So I'm right there with you. I think if we could get one test in this patient, it would be to rule out infections and get PFTs to prove out an asthmatic component. But I think at this point, if I were this patient or a family member, I would ask to become Cushingoid pretty quickly because the organs are certainly at risk for it.
Excellent as usual, Rabih. So anyway, ask and you will receive. His autoimmune screen result came, his P anchor was positive and his abundant anti-MPO antibodies. All right, so now, so I'll just present briefly the treatment, and then before the final review, we'll entertain a final diagnosis. Is that okay? All right. So as rightly as you said, Noah, this gentleman needed, actually, we just supported his ventilation on NIV and immediately was commenced on pulse IV methylprednisolone. Unfortunately, even after a week, we could not wean him and he was still very hypoxic. So we added IV cyclophos. But even after another week of IV cyclophos, we were still not able to get him off ventilation. So we subsequently added rituximab. Now, as for the first case, we used the usual steroids, but because we were trying to decrease his dependence on steroid, we decided to add a biologic on him, and we started him on an anti-IL-5 receptor, which is Fasenra or benzarulimab. All right, so we shall go back to maybe since we're on this case, what do you think is your final diagnosis, and based on what points? Then
Well, I think for the second case, the second case is the Pienka and MPO positive.
yes.
I think that EGPA will be my final diagnosis here. And then the first case, you said that we stopped the medication and discharged on inhalers and returned with wheeze. And I also think that the first case, we still haven't evaluated fully enough to exclude EGPA, and the IgE cascade being negative for ABPA. I think that EGPA is more likely, and then less likely to be a other hypereosinophilic syndrome with the mutations that that Rabih mentioned. What do you think, Rabih? Would you agree both cases EGPA, a spectrum of disease like you were mentioning?
Yeah, I'm right there with you. I think that unfortunately there's clarity on the second case simply because of how advanced the disease is. And the diagnostic uncertainty that exists in the first patient is simply a matter of where he is in this snapshot of time. And so I think the range of diagnostic possibilities in him, the first patient, are a severe restricted lung disease, either severe asthma, which is a diagnosis weakened by the alveolar features, or severe chronic eosinophilic pneumonia. I think both of those are plausible because we have yet to demonstrate that he has systemic features that allow him to bleed into the hypereosinophilic syndrome category or the ANCA negative EGPA category. So I think for the first patient, I think the lack of clarity in my mind is merely a function of the fact that his disease is contained here. And ultimately, time will tell. If he stays like this, then he gets one of those two diagnoses. If he starts to evolve and starts to become refractory, then I think it becomes a debate of whether he has hypereosinophilic syndrome or he has an ANCA negative GPA.
Right.
But I'd love to learn from you, Usha. How are you
All right.
conceptualizing this?
So I think, I mean, Rab, the reason why I presented these two cases is you are right. They are both cases of EGPA. Now, basically, EGPA is a rare disease, but we have got two different spectrums. It's heterogeneous, and as Rabih rightly says, it can start off with the allergic asthma phase, followed by the eosinophilic tissue destruction phase, followed by the vasculitic phase. So we start with, I think with case B, acute. I think when he presented, really, it was not a problem of diagnosis because you had a gentleman who presented with high eosinophils, multi-organ involvement, lung, vasculitic features, and eventually an anchor that is positive. So the problem with second case was a management problem. And that was difficult because most of treatment guidelines for EGPA, really the only evidence-based really is recently in terms of the biologics. Otherwise, it's all just sort of traditionally what we use for other this sort of alveolitis, alveolar hemorrhage. So starting with steroids, he did not improve. Then we added cyclophos again. And finally with rituximab, after 2 to 3 weeks, we managed to wean him off. So again, the spectrum there was one of mainly vasculitis with positive anchor. Now, the first case really was the usual, where you see asthmatic patients, you review them regularly, and the problem there was the diagnosis. So we were perplexed because he was so steroid dependent, and we did think of a differential, but his eosinophils were normal. So, and we could not explain plain asthma with the CT findings. So, but because we thought it was some form of organizing pneumonia, autoimmune screen was negative, we proceeded with a PET scan. It was not FDG-AVID, and he was quite well. He's a huge fella. He absolutely refused any form of pinprick biopsy, etc. So what happened is, these things, we are multidisciplined because of his Cushing and his exogenous steroids. I had referred him to my colleague, the endocrine physician, and she sat him in, called his family in, and made sure he cleared his home of all the traditional treatment, refused him any access to the Chinese traditional doctor. And 2 months when he came for his next follow-up, he had his routine blood test. And when I saw the blood results, and I saw a raised eosinophil, which is 12%, not exactly the level with HES, hypereosinophilic, and it was an oh my God moment, a eureka. Because this is the first time in a year that his eosinophils were raised, simply because he was off his traditional Chinese treatment for 2 months. So again, then it seemed, why did we miss it? He was in asthma that was steroid dependent. Every time he was off the steroids, he felt bad. That's why he kept taking his traditional treatment. And because of that, we could not fulfill the criteria of raised eosinophils. But after that, he had fleeting migratory shadows on his CT, sinusitis. So obviously, we diagnosed him as EGPA, the allergic variant, and started him on a biologic, an anti-IL-5 receptor. After 3 months, he was off his steroids. His lung function had back to normal, and he was well.
Even if we have to wait another 5 years for your next case, I think it'll be well worth it. What an incredible. This is a master clinician telling, describing a very complicated disease in such a poetic way. I don't even know what to say, Usha, but I'm very, very grateful that we have access to your incredibly thoughtful and intellectual brain. It's so powerful. Thank you. So I don't think there's any other way I have ever been exposed to the eGPA illness script than today. And to imagine an early learner who's getting this exposure now, you have set them up for success for the rest of their lives, quite frankly. So thank you so, so much.
Thank you. Thank you.
Noah, what are your reflections?
My reflection is that I'm the early learner, and I will always remember this case when faced with eosinophilia and concern for eGPA. It was a beautiful presentation. Thank you so much, Usha, for bringing this case to us.
Thank you.
And thank you, Rabih, for having me.
Oh, of course. This is your space as much as it is mine, my friend. Big shout out to Simi for scribing 2 complicated cases. And I love how creative you got with the whiteboard, Simi, having them visually be much easy to see. Thank you so much. As promised, Sarah, I mean, the whiteboard would be full. I didn't think it would be this full. Take it away.
Can you hear me? Yep. Great.
Yes.
So for our teaching points, in case 1, we discussed that asthma tends to present early in life due to intrinsic vulnerability coupled with environmental triggers, and it's unusual for a patient to have a new diagnosis in their 60s. So if they do, they should be fully evaluated with PFTs and methacholine or bronchodilator challenge, if not already done. In case 1, the Cushingoid habitus told us that the patient had received a lot of steroids and that asthma should be steroid responsive. So this tells us that it was a misdiagnosis. Alveolar disease also indicated that it was either not asthma or had become a complication of steroid use, such as a infection. The reasons why an ADM cortisol might show up negative in a patient with Cushingoid features include that the exam is imperfect and you may not necessarily have the right features just looking by exam. And steroid exposure and then having cleared the last dose might make it so that they have a negative ADM cortisol. And then also taking steroids exogenously that are not picked up by the lab. And then the eosinophils in this case being normal didn't necessarily exclude their role in the disease process. All exogenous steroids should be stopped in order to prove that somebody has eosinophilia. ABPA and EGPA can present with consolidation and reversible obstruction. And in this case, the negative ANCA made EGPA less likely, though there is ANCA negative EGPA. EGPA also causes bronchiectasis. So interesting that that wasn't present here. And then ABPA should be ruled out by antigen testing to prove that it's not there. And then hypereosinophilic syndrome is challenging to distinguish from EGPA, but it's easiest to distinguish it from ANCA negative disease by biopsy showing granulomatous disease or showing specific mutations in the eosinophils that are associated with HES. And then chronic eosinophilic pneumonia is a diagnosis of exclusion requiring the disease to be restricted to the pulmonary tree. Parasitic syndromes would be likely to cause more systemic disease over the course of a 3-year span, especially in case 1's context of him having lots of exogenous steroid use. And then in case 2, the patient had bloodstreak sputum, which clued us into there being intrinsic pulmonary disease. So in this type of patient, chest imaging can be helpful to characterize the extent of pulmonary disease. The rash, weakness, and gait disturbance in context with that bloodstreak sputum helped us clue in that those were kind of extrapulmonary manifestations of a pulmonary illness. And then hypoxia plus crackles were a clue that there was an alveolar problem. And then the purpura with neuropathy and weakness made us concerned that the lung involvement was diffuse alveolar hemorrhage from vessel ischemia, which made us concerned for small vessel vasculitis. In patients who have small vessel vasculitis, CT chest with UA and CBC with differential will be helpful in characterizing the extent of lung disease, eosinophilia, and possible GU involvement. And then EGPA develops over years. So patients can present with a very broad spectrum of disease manifestations. And in general, patients start with asthma, then get extrapulmonary manifestations, including GI and cardiac involvement. And all of these are eosinophil driven. And then the final stage is vasculitic, where patients start infarcting their organs. And we saw that whole spectrum of disease in these 2 cases.
Can you guys believe this is her first time doing teaching boards? That was unbelievable. So for somebody going into neurology, it's mind-blowing because I think you would make an outstanding generalist, Sarah. That was really, really cool. Thank you so much. And you did all of that in 3 minutes. Unbelievable. Big shout out to everybody. Usha, a lot of gratitude. Thank you so much for being here.
Thank you.
Really look forward to the next time.
Bye-bye.